Hello, good afternoon, and welcome to this afternoon's Parkinson's Academy webinar, being sponsored by Profile Pharma. So thank you to them. The first session this afternoon will be kicked off by Gemma Cummins, followed by Patsy, discussing all aspects of neuro examination and how patient-initiated follow-ups fit into this.
So hi, and thanks very much to the PD Academy for inviting me to speak this afternoon. So I'm a consultant neurologist based in Manchester, and I have a specialist interest in movement disorders. So today I'll be talking a bit about the principles of the Parkinson's exam, and as I said, just some of the red flags, and then also how best to perform the virtual consults. So with all the changes that we've all been experiencing over the last couple of years, be really sure to know that one thing that hasn't changed is the diagnostic criteria for idiopathic PD. So you must have the presence of bradykinesia or slowness of movement, and then at least one of the following: so muscular rigidity, the presence of a rest tremor, which is typically 5 cycles per second, or postural instability. There's a large list of the exclusion criteria for idiopathic PD that you need to be aware of. So for example, if you have a patient who's a history of multiple strokes, and when you examine them, they have lower body Parkinsonism, this may suggest they have vascular PD rather than IPD. There's rare conditions like encephalitis, where the virus can attack cells in the substantia nigra, giving rise to symptoms of Parkinsonism. During the history taking, you need to ask about antipsychotics or drugs like sodium valproate that they may have been on, because this may suggest they've drug-induced Parkinsonism. And when you're examining a patient with Parkinson's, there can definitely be clues to whether you're dealing with IPD or atypical PD or atypical Parkinsonism. So with PSP, you get classically early falls and early freezing within the first couple of years, and a supranuclear gaze palsy. You can have autonomic features, of course, in idiopathic PD, but if these occur early on and if they're very severe, like an MS, this can suggest conditions like MSA. There are other conditions that mimic Parkinsonism, so hydrocephalus, and this is important not to miss because it can be treated surgically potentially. There can be clues when you're examining a patient with hydrocephalus. They don't typically get the unilateral rest tremor that you get in IPD, but they can get freezing of gait and difficulty initiating gait. So there are also supportive prospective positive criteria that help you in diagnosing IPD. So unilateral onset with the rest tremor is classical. Obviously it'll progress over time, and you would expect patients with IPD to respond very well to levodopa, and about 50% of them after 5 years will develop dyskinesia. People often joke that the smartest neurologist is the last one to see the patient, and that's often the case with these atypical Parkinsonian disorders. So they can be hard to diagnose early on, and then after a few years, it gets much easier to tell what they have. With the NICE criteria, from putting patients with PD forward for deep brain stimulation surgery, for example, they say the patient should have symptoms of Parkinson's for at least 5 years, because if you do the surgery earlier, you might accidentally put patients with atypical PD forward for the surgery, and they would have worse outcomes. So bradykinesia, so this is critical to the diagnosis of PD, and it correlates, one of the signs that correlates best with dopaminergic deficiency. You can often, when you're taking the history, it's going to be the spouse that comments more on the slowness of movement. They might have actually noticed it more than the patient themselves. And to diagnose bradykinesia based on the criteria, you have to be able to demonstrate in a limb. So it's not just enough to say, oh yeah, the patient feels they've slowed down in movement, or you feel they look generally slow in exam. You have to, as I said, be able to list it in the arm or leg. So I do usually finger tapping, hand tapping, and foot tapping. Some people also do kind of get the patient to demonstrate as if they're playing the piano. You're not only looking for slowness of movement with bradykinesia, you also need to see a decrement in the amplitude of the movement. And in Queen's Square, there was a professor who used to say that you should do the hand tapping at least 64 times to say if it's really bradykinesia or not. I think in real life consultations are probably a bit too short. Most of us probably don't really do that. You can see other manifestations of bradykinesia during the consultation. Hypomimia is a sign of it. Also reduced arm swing on walking, the reduced blink rate. Patients may be drooling because they've impaired swallow. When you ask them to shrug their shoulders, it can be very slow. And this video here, you can see this patient has slowness of movement in her left hand, and also there's a decrement in the amplitude there as well. She's a slight tremor in her right hand too. And she's also, I think, bradykinetic on the right side, but it's less pronounced there than on the other side. So tremor, when you're examining tremor and Parkinson's disease, you often just get the patient to sit initially with their hands in their lap. You might ask them to close their eyes and count backwards from 100 or do serial sevens to see if this distraction technique might make it more obvious. The tremor can be very subtle in PD, might even just start in one finger. Sometimes during the consultation, you may not even notice the tremor when you're talking to the patient, but then when you get them to get up and walk, it becomes much more obvious that they have a tremor on one side. In IPD, patients can also have a tremor affecting their chin, lips, or tongue. We don't typically see a head or voice tremor with idiopathic Parkinson's disease. And if you see this, you'll be thinking more along the lines of essential tremor. People talk about re-emergent tremor with PD, and this just means that you see a pill rolling tremor when the patient's sitting down relaxed. And then when you ask them to raise their arm in the air, the tremor might disappear for a few seconds before it kind of re-emerges again. You can have tremor as the initial presenting sign in atypical Parkinson's, but it's less common. And in PSP, for example, the tremor tends to be bilateral rather than unilateral and present more at action than unrest. A clue to the diagnosis of MSA is sometimes the nature of the tremor can be quite jerky or almost myoclonic rather than the typical pill rolling tremor you see in IPD. And although rest tremor is what we think of classically at IPD, of course, some patients don't have it at all, and they have more an akinetic rigid variant of Parkinson's. And a lot of one in 5 patients with Parkinson's will have an additional postural tremor in addition to their rest tremor. So this is a case of a patient who had some features of Parkinson's, but the tremor just didn't look entirely typical of what we'd see in IPD. He also had some symptoms and signs of ataxia and had a diagnosis of peripheral neuropathy. His wife had noticed some problems with his memory over the last couple of years, and he developed very pronounced autonomic dysfunction. So he'd become incontinent of urine and had severe postural drops to the point he was sometimes falling with them. So he's a bilateral tremor here, but it's more pronounced on the right and the left, so of a moderate amplitude tremor.
Good, and then can you hold them out like this?
And you can see there's nearly almost present proximally in the right upper limb there as well as distally.
In, and then touch the white stick. Sit and touch your chin, touch the white stick. Good, and then do the same with your other hand. Chin, good.
You can see there an intention tremor, and he has a degree of finger nose ataxia as well.
And okay, and just stand there for a minute and
You walk a couple of steps now. Right foot first, love. Right foot first. Right foot, left, right, left, right, left. That's as far. I've got to take.
Yeah, so I think you can see there that as well as having difficulty initiating gait, he's also a broad-based gait, so he's ataxic as well. And because of some of these atypical features, we went on to do an MRI brain scan, and this showed this kind of classical sign of bilateral high signal in the middle cerebellar peduncle. And this can be seen in the condition FAXTAS, or Fragile X-associated tremor ataxia syndrome. And we went on to do genetic testing of this patient and confirmed a mutation in the FMR1 gene. FAXTAS, sometimes you'll get a family history of intellectual disability or Fragile X in the relatives in the family, and it can occur in females, but it tends to be a lot more mild and less common. It's not uncommon to see different truncal and postural abnormalities in the movement disorder clinic. They can affect both patients with idiopathic Parkinson's disease and atypical Parkinson's. Here there's a patient with Pisa syndrome, so like the leaning tower Pisa, you get them leaning quite dramatically to one side, so kind of lateral flexion of the trunk. We see this in IPD, but also the atypical disorders like MSA. Camptocormia can be a very debilitating symptom for some patients, tends to occur a bit later on in the disease course. And here you get forward flexion of the thoracolumbar spine. And according to the definition, it should be more than 45 degrees. Now, this can be difficult to treat. Some patients respond to dopaminergic therapies or Botox injections. Generally, the treatments are, not very satisfactory for it. Occasionally, it can be dopamine agonist induced or worsened by dopamine agonists. We see this retrocollis, or kind of backward extension of the neck, classically in PSP or progressive supranuclear palsy. And in PSP, you want to examine their neck as well, looking for neck rigidity, and they can have axial rigidity as well. Whereas often in PSP, interestingly, their tone won't be that much, won't be very increased in their upper limbs compared to IPD. This is a patient with MSA here with anticollis. Sometimes they can develop a full head drop. We do see that in other neurology conditions as well, such as neuromuscular disorders like MND or myasthenia gravis.
Okay, so can you just stand up for me and set up?
So when examining the gait in Parkinson's, I think it's always good just to, watch the patient as they come in from the waiting room. Even that alone can give you a clue to diagnosis. Sometimes the patient might be walking inappropriately quickly, even though they clearly have poor balance. We see that sometimes in PSP patients. Patients sometimes with stooped gait, it might be flexed, their arm might be held and flexed by their side. They'll classically have this reduction in arm swing. They may be festinating, they may be freezing. And you can see on block turning demonstrated quite well here in this video where she freezes on turning. So it's good as well just to pay attention to the speech and breathing patterns, because they can give you clues to the type of Parkinson's you're dealing with as well. With IPD, of course, you get hyperphonia and a monotonous voice. With MSA, you can hear kind of very high-pitched dysarthria, and often their speech is both spastic and ataxic components. This is very different to the speech we hear in PSP. They can be gravelly or growling, and often over time, unfortunately, becomes very unintelligible. Patients with PSP you might hear constant groaning, and in MSA you sometimes hear stridor. So this is a very kind of harsh, strained sound. It's high pitched and it's more commonly heard in inspiration. And sometimes it may be the partner or the patient that says they hear it at night, but over time sometimes can be present during the day as well. And there was one study that showed, it's quite that in MSA that maybe if it appears early, it may be associated with shorter survival. Sometimes you use CPAP as symptomatic treatment, or patients even go on to need tracheostomies. Observation of facial features can be useful as well in the PD clinic. Here we have a patient with idiopathic Parkinson's disease, and you can look for greasiness of the skin over the forehead and nose, and any red scaliness of the skin. So you see that in seborrheic dermatitis and IPD. This lady here is MSA, so she has this dystonic posturing, kind of grimacing of her facial muscles. And this chap here, you can see the overactivity of the frontalis muscle and procerus muscle just above the nose there. And this together with this kind of staring or startled expression can be indicative of PSP. This is the picture of the cold hand sign you see in MSA. So if you shake the patient's hand, you might feel cold to touch. When you press on their nail bed, they kind of reduce capillary refill time, and the hands just generally looked a bit mottled and have this kind of purplish discoloration. There's all kinds of other signs described in the literature. So even things like the winter sandal sign that you see in Parkinson's patients are on dopamine agonists or amantadine that have caused bad ankle swelling. Just stop this here. So this is a patient here who has progressive supranuclear palsy, and just want to demonstrate in the first video is a positive applause sign. So to test for the applause sign, you ask the patient to clap but you do the same number of claps that you do, and you clap 3 times. And if the patient keeps on clapping beyond that, that's called a positive applause sign. Now, initially, this was thought to be specific for PSP, but it's been increasingly recognized now that it occurs in other disorders like behavioral variant FTD, cortical basal degeneration as well. Okay. This is a demonstration of the eye exam in PSP, and one of the key characteristics that you look for in the eye movements is slowing of downward gaze. People with age anyway can get loss of vertical up gaze, the loss of downward gaze, it's more specific. So you can see slowing of horizontal pursuits there. And I think you can see there that he has some restriction in vertical up gaze and down gaze.
Just look straight ahead. And can you look to your left for me, please? To your right.
Saccades are slow there.
Now I'd like you to look up and now down.
And that's the very classical sign there, that slowing of downward saccades.
Just look up and look down.
Okay. And moving on, then this is a patient with multiple systems atrophy. So she's a 65-year-old lady presented with a 4-year history of left upper limb rigidity and stiffness. She had quite pronounced bladder symptoms, and in examining her lower limbs, she had upper motion neuron signs. She had very hypophonic speech.
Can you tap your fingers like this for me?
Hand movements there are slowed, and you can see the anticollis there that I mentioned earlier of her neck.
Yeah, that's great. It's fine, thanks.
Okay. This is a demonstration of, this is a video of a patient with young onset Parkinson's, which I thought would be useful to show, just because sometimes they can look so different to patients who present when they're older, and they often have a much greater degree of dystonia. So this is a 28-year-old lady. She was born normally. She met all her normal motor developmental milestones, but she developed a limp at the age of 14, and then a tremor in her hands at the age of 19. Developed difficulty with handwriting and just reported feeling generally a bit slow and stiff. She described herself in the clinic room. She said, "Oh, I think I walk like a penguin." So you can see here her gait exam. So she had quite a marked degree of dystonia in her lower limbs and her upper limbs. And she walked with this very broad-based gait. So she had a mutation in the Parkin gene, which is the most common genetic mutation that we see in patients with young onset PD. So if you're a betting person, you put your money on Parkin when sending off your genetic tests in these patients. With young onset Parkinson's, there's often these delays to diagnosis, as sometimes the patients will go to their GPs and they'll be describing just pain and stiffness in their upper limb. They might get sent initially to the musculoskeletal clinic rather than the neurology clinic. I think sometimes what clouds the picture as well is that they can have premotor symptoms like depression and anxiety. So sometimes they get labeled as functional, and they don't always present with this, the more classical unilateral rest tremor, which can throw people off a bit. But that, in addition to the fact that people just don't expect to see it as much in under 50s. So can we diagnose Parkinson's disease accurately in a remote clinic or kind of a video consultation? So I'd say kind of a qualified yes here, and there probably has been thousands of patients diagnosed over the last couple of years during the pandemic this way. You can get a good history remotely via video consultation, or usually as good as you can face to face. I think some of the problems that you have with patients face to face, such as if they have low voice or cognitive problems, I mean, you're going to run into these remotely as well. the diagnosis of Parkinson's disease, it's generally straightforward. I mean, if you refer to a 70-year-old man who has lost a sense of smell, slowness of movement, and a unilateral rest tremor with long-standing constipation, there's really a limited differential diagnosis for this. And like with most conditions, they say that really 80% of the diagnosis is in the history anyway, with about 10% being in the exam and just 10% in ancillary testing like imaging. I think personally, I'm sure a lot of people agree with this, that really the gold standard of examination is still going to be in-person consultations. But we can get a lot virtually, and certainly a lot of the Parkinson's diagnosis based on observation anyway. We can do the UPDRS remotely, apart from a couple of sections of the motor UPDRS, so rigidity and balance can't do. But you can do bradykinesia and all the other things quite well. I would say as well that, I mean, even whether we're diagnosing patients face-to-face initially or remotely, even in the best hands of the most skilled, experienced movement disorder consultants, still get it wrong about 10% of the time. And sometimes you just need to follow up the patient anyway to see what's going on. So to make things run smoothly when you're having the remote consultation, I'm referring here to video consultations rather than phone ones. But if you have good support staff, that's helpful, so you can get them to send out a template letter beforehand, kind of tailored for your PD patient. So what's quite helpful here is that the King's College PD team have put together a leaflet that they send out to PD patients before their appointments in clinic. And you can find this on the parkinsons.org website under the information for health professionals. So you can put things, when you send out this letter to the patient, you can remind them of things like to bring their medication list with them, to have somebody there with them when you're examining them so that they can adjust the camera to see they're walking. A lot of patients have blood pressure monitors at home now, so you can ask them to actually check their blood pressure lying and standing before you review them. And then there's other ways you can tailor your template letter. So thinking of things like maybe their speech gets really bad when they're off, and that's going to make things difficult during the video consultation. So you can mention that they should try and take their medication and to be on at the time that you're reviewing them. In terms of your room setup, I mean, if you're doing the appointments from home, I think it's just common sense, really. You just try and keep it as professional as you would in the clinic room, good lighting, avoid distractions. You want the patients to, feel that they're in a private space and that. So when they've kind of done studies and asked patients to feedback on how they found these video consultations, one of the feedback's generally positive. The main negative feedback tends to always be to do with loss of internet connectivity and technical issues that they find frustrating. So depending on where you work, you'll use different platforms such as Access Anywhere. The main thing is that they're just easy to use for both the patient and the clinician. Ideally, when you're examining the patient, you want to have space behind them so that you can ask them to walk. And I think ideally, if they have an iPad to use, that's better. Probably an iPhone or smartphone is second best. And then after that, a desktop is less useful just because it's harder for their spouse, say, to maneuver the camera so you can see they're walking and other things well. You can do general inspection, I think, quite well remotely. Eye movements, I think I struggle with more. I think it's very easy, difficult to pick up the minutiae, like things like square wave jerks and that. Much easier to do this in person. Bradykinesia can easily be done virtually, but the thing is usually to make sure that the person is in shot of the camera, because they often won't be unless you prompt them about this. And I usually tell them, to try and sit about a half foot away, just to sit a bit further away from the screen when you start that part of the exam. You can ask them to write online. You can ask them to pour drinks to examine their tremor, again, just all the time trying to make sure that they're in shot of the camera. And walking I think can be quite interesting when you're doing these remote exams. You really get a feel, I suppose, for how hard sometimes the patient's day-to-day life is, as you see them sort of freezing and trying to navigate around their cluttered sitting rooms, which you don't always pick these things up when you're sitting with them in the hospital clinic room. We can even do the cognitive assessment remotely now. So there's this mock test blind that's been adapted for phone or video consults. It's very similar to the regular mock, but they've removed the visual parts of the testing, like the trail testing and that, and it's marked out 22 instead of 30. And you can find that online here at this link. So although there has been several studies that have shown that patients really appreciate, certain patients anyway, the comfort and convenience of teleconsultations. There are some things just to be aware of. We still don't really have long-term data on this to see whether we're as good at diagnosing patients remotely as we are in person. I think over time, as we do more prospective studies, this will become clearer. And can do things like rigidity as well. We're going to miss some subtleties of eye movements and some other things on exam like stimulus sensitivity. Another thing that's perhaps more concerning is that, of course, often these Parkinson's patients are older and might have more than one pathology. And sometimes it happens when you are seeing a patient face to face, they say, oh, I've gone off my legs a lot more of the last couple of months. And when you're seeing them in person, you examine them, look for signs of cervical myelopathy, for example, where they have brisk reflexes and extensor plantars, and you might lose some of that with the remote review, which could potentially be serious. And as well as that, I think kind of doing these remote consultations, it's much easier if you already know the patient's been under for a few years, and then you move to remote consultations, you've already built up that rapport. It's a little bit more difficult with newer patients. You do lose out with some of the, I think, the non-verbal cues and things, and that's just something to bear in mind. So thanks very much for that. And I'll take some, I think we'll be taking questions after Patsy's talk there.
Thank you very much, Gemma. That was a brilliant synopsis of the new world that we're living in, and I'm sure questions will be coming in. A huge thank you again to Profile Pharma for supporting this webinar. And now on to Patsy Cotton, who will be talking about patient-initiated follow-ups. Patsy.
Thank you very much, Jada, and thank you very much for inviting us today, and for the audience for attending on a Friday afternoon, which is very much appreciated. So what I'd like to talk you through really is not only the examination, which Gemma has done so beautifully, but how do we follow up our people with Parkinson's. So I think I probably know quite a lot of the audience. I've been around a long time. I'm Patsy Cotton, and I work in the Greater Manchester Neurosciences Unit, and I also work as one of the clinical leads in the Parkinson's Excellence Network. And I have assistance with my slides, so could I ask for the next one, please? Okay, so it's the challenge. It's the challenge in the consultations, and it's the challenge in the follow-up. As clinicians, how do we decide on when the next appointment should be? Is it going to be 2 months, 3 months, 6 months, a year? And that's very much clinical judgment. And sometimes it's also patient-led, even in a face-to-face clinic, when you might say to somebody, I'll see you in 6 months, and you see perhaps maybe they're not looking too happy about that. And then you say, would you like to be seen sooner? And they say, oh yes, please, 3 months would be lovely. So sometimes as clinicians, we're led by patients, and so we should be. And when we do that, are we encouraging people to self-manage? That's the question I would ask. What we want to do is we want people with Parkinson's to take control of their lives, to take control of their management, to take control of their medication. They're living with this condition 24/7. So how can we encourage this? And what are the next steps that we should be taking? And what I'd like you to talk through with you today is my experience on patient-initiated follow-ups. Not a new concept, but just to see your thoughts around it and to share with me my experience since January 2021. And what I'd like to say as well is that one consultation does not suit everybody. And again, that's something that we need to be very responsive to. And hopefully then we will have time to take any questions that if we don't have the answers to, we might find somebody who does. Okay, so how do our consultations, how are they perceived by people with Parkinson's? Do we actually know? We have patients, we have carers, we have their loved ones who come to clinics with them, and also when we do remote consultation, whether that be by a video link or a phone, how do we know we're getting it right? And not only ourselves, but also our colleagues, our consultant colleagues, our nurse colleagues, and also our therapist colleagues. Okay, so what is patient-initiated follow-up? Okay, so it's following the idea and the health model that patients know best. It's patient-facing, it's a digital platform. It's been around since 2008, not just since the pandemic. It's clinical teams, how they manage care delivery, and also how we empower patients to take control of their health. Now, this is a concept with Parkinson's and people living with Parkinson's that we've been looking at for the last decade. So patient knows best. It's a proven model for patient-initiated follow-up. Now, you can find this referenced in NHS England's latest guidelines, and also it's in the operational plan for 21 and also 22. Okay, so as I said, this patient-initiated follow-up, referred to as PIFU by many, is known by many names. Okay, so open access, patient-led follow-ups. I think that going back over my time in Parkinson's, I've known many of my colleagues who've had drop-in clinics. We've supported self-management with people with Parkinson's, and this is through self-management plans, self-management platforms. We've had open appointment systems where people can just book in when they feel they need to. We've had patient-activated care. We've had open self-referrals, personalized follow-ups, and in cancer care, we've had something which is initiated as stratified follow-ups. And now we're getting back to remote monitoring, which of course we're all familiar with, and it's been around for the best part of 5 years now, with patient kinetic graphs. We've also used clinical questionnaires, motor function, non-motor function. And what we're really looking at through all of these, regardless of what the title is timed follow-ups based on individual need rather than things that are just set intervals. As we know, Parkinson's is complex. It's not set intervals. People fluctuate. And perhaps we need to look at a model that's going to fluctuate with the condition and with people with Parkinson's. Okay, so this is how I started. And I have been running a patient-initiated follow-up service since January of 2021. And why? It's particularly because it was a new service with 400 people in an area in Greater Manchester which had lost their Parkinson's service for the best part of 3 years. So how was I going to go into this and look after 400 people with Parkinson's who I never met? Okay, so one has to put the pin in the map somewhere, and how are we going to look after everyone? I was fortunate at this time as well to have an experienced colleague with Parkinson's come to join me. So there was a full-time nurse, and I was doing 2 sessions in an outreach clinic. So I'm going to talk you through it, and I'm not saying it's perfect, and I'm learning all the time, but that's the nature of Parkinson's. Okay, so what we started was we didn't have available to us as nurse appointments, face-to-face consults. So what we were doing is our consultant colleagues were seeing the patients face-to-face who needed to be, and then it was over to us. So we would phone patients, and at the end of that consultation, people were saying, when will I get to see you? Knowing that that wasn't possible, the best possible thing that I felt that we could do is that we could ask the patients what they thought they needed. And in this, I was asking people, would you like another telephone consultation? Would you like us to arrange a video consultation? Or, if possible, would you like a face-to-face consult? And people would say, oh, nobody's ever asked me that before. So it's very, very important that all our consultations are always documented, as we do, and we had to have a clinical outcomes letter. And that always went to the GP and also to our person with Parkinson's. And within that, we were signposting people to tell them that if they needed help and support in between their next planned contact, they could do so by a telephone number, which is linked to an extremely excellent secretary, or they could do it by an email, so that you were trying to cover all bases, whichever might have been easier for the person with Parkinson's, their loved one and their carers. And then we would update our clinical information at the end of the consult. So we were really saying to people, we will see you or contact you within 6 months. You're telling us how you would like that contact to happen. Okay. And then we would also organize as well that if that person needed help or support in between that appointment in 6 months' time, they knew exactly what they should be doing. They knew exactly who they should be contacting, and they knew what was going to happen. Okay, I have for many years had telephone patient helplines, and with that helpline, we never had really particular set time to answer those calls, and indeed one call could take you half a day. And then that would delay you from getting back from somebody who might have been waiting for that phone call. And on a number of occasions, you might try somebody 3 times to contact them, and you didn't get in contact with them. And then somebody would turn up in clinic and say, "Patsy, you never returned my call." Well, I did try, but again, you know, it might have been documented on our electronic system, but the patient felt that they had not been contacted by you. Okay, so nurse telephones patients to undertake the triage. Next slide, and I'll continue on that. Okay, so what happens is that when we were setting this service up, so patient-initiated follow-up, by definition, would mean that the patient tells us when they want our next appointment. And I thought long and hard about this, and I discussed it with many of my colleagues and therapist colleagues as well. And the fear there was that perhaps maybe we might miss some triggers as healthcare professionals if we left it to the patient to just say, get in contact with us within the year. So what we're doing with our patients in East Cheshire is we're giving people a 6-month appointment with the nurse, and all our patients are seen by the consultant with a face-to-face contact annually. So there's 2 points of contact there which are booked in. So the patient phones through, they need to speak to a nurse. We have a telephone clinic which triages that patient to find out what they need, and then we either follow them up in the telephone clinic, see them face-to-face, or do a video link with them. They're fast track if from the telephone triage that they need therapist input, then we refer them to the therapist. And I would say that it's a better way of fast tracking patients, because we're then saying to our therapist colleagues, this person with Parkinson's has contacted me, A, B, C, and D is not working. Or this person has contacted me, they are having numerous chest infections. Salt, could this be diarrhea? And if somebody all of a sudden develops falls, we're picking up, I would say, you know, more postural hypertensions earlier on than previously, because we're not just waiting for the next review. And so many times I would be saying as well that sometimes people would come to consultations and they were doing pretty well. And they came all that way, waited in the clinic to come in for me to say to them, yeah, you're doing really well. And that maybe time could have been well spent with somebody who wasn't doing so well. If the patient requires just advice and guidance, they can have that during just the telephone clinic, and then they don't need to go on to an appointment. All contacts are documented, all contacts are followed up with an outcomes letter. And if the patient then needs a face-to-face appointment or a virtual appointment, then we can do that within the week, because we have urgency slots within our clinics to manage people who come through. So all in all, I would say so far so good. The outcomes and from people, patient feedback, relation feedback, it's been rather positive. Okay, so follow-up care. Why do I think that this is working? And it's not just my gut feeling, okay? People tell me it helps relieve their fear. Now, whether that be particularly due to the pandemic, I can't tell you that because it's only started in January 2021. But people feel that they, not only do they have a telephone number, they also have an email address, and they know they are going to be contacted. They're not just leaving a message. They know that they are going to get a contact on a Tuesday because that's when the telephone clinics are. I've also noticed that people are taking better control. So this is not an emergency service, and I'm not pretending that it is. It is not. So if we have somebody, you know, who gets in touch on a Friday, then there's nobody to answer that initial consult. So I have people turning to where they should be. They're turning to their GPs and they're going to A&E. They are not waiting for somebody like myself to say, you need to go to see your GP. I think you have a urinary tract infection. I think it offers greater flexibility should the circumstances change, because what you're saying to that person during their consultation, if anything changes within the next 6 months, please contact us. And that includes people who might have dysregulation syndromes, compulsive behaviors. If you notice any changes, contact us. And from a medical legal point of view, of course, that's documented. You're asking people to get in touch with you if things change. And I hope that that's more shared decision making, and it's empowering people to make up their own decisions. Therefore, are we getting closer to more personalized care? I know it's, you know, less unnecessary trips to hospitals and clinics. It's saving time, not only our time, not only NHS time, but people with Parkinson's, their carers and their loved ones. And I hope it's also reducing stress. And, you know, I have to go back and reiterate once again that one type of service does not suit all. Okay, so how do you start to rearrange telephone appointment systems, clinic appointment systems? You have to have buy-in from your trust, and you have to have a coordinator. You don't want to lose control of your patients. You don't want them to be lost to follow-up, as we frequently have heard previously. And therefore, people with Parkinson's feel nobody cares about me because nobody's contacted me. Okay, so I would say to do a pilot. Start small. Given one particular area, like I was able to do in East Cheshire, made it much easier. Always make sure that you have your clinical outcomes, most important. And the D part is what I'm starting at the moment. I've had verbal feedback, but I now want to audit it much more aggressively and vigorously, just to make sure that I'm reaching all people with Parkinson's, carers, loved ones, and also feedback from therapists and my medical colleagues, my GP colleagues. How do they feel this is working? If it can work in a pandemic, I'm sure it can work going forward. Okay, one thing that NICE guidelines, well, not just the guidelines, but one thing that came out in NICE in 2020, which I want to share with you, I think it's really, really important that we all make every contact count. How very, very important to get the balance of patient need, clinical need, and getting that assessment right. And our outcome measures have got to be patient safety first and foremost. We all want to deliver high quality care. That's why everybody who's on this review today, this webinar today, we're here because we all have buy-in to high quality care for people with Parkinson's. We want to be responsive, we want to be reliable, we want to be reactive, and we want to offer people right care at the right time. Okay, the challenges, as started in the beginning of my presentation, do we need to look at changes in consultations? Do we need to relook at patients' reviews in our practice? How can we encourage self-management? People with Parkinson's taking control. Are the next steps patient-initiated follow-ups? And just always to remember that whatever changes you might make in your practice, one consultation does not suit everybody. And one thing that I've also followed up as well is that as a result of doing patient-initiated follow-ups, what I found is that I've now reorganized so that I do one evening clinic a month, and that's a virtual clinic. So many people with Parkinson's who maybe wanted a daughter, a niece, a nephew, a grandchild to come with them to clinic, but they never could because they couldn't allow to take the time off work. This is allowing us to renegotiate what suits people. Thank you very much for listening.
Thank you very much, Patsy. So maybe some good has come out of the pandemic by putting that patient in the middle of that service and giving them control. It's a really, really interesting concept. So huge thank you. I'm going to take a few questions as they're coming in. So Sally Roberts, for you, Gemma, for patients that don't have access to a PC, actually could be for both of you, how much merit do you give assessment for diagnosis over a telephone consultation?
I just unmute myself. Yeah, I mean, I've kind of done a mix of both. I think somehow it depends a little bit as well on the quality of the referral that you get from the GP. So I've had letters from GP where they've said quite confidently, you know, this patient has a unilateral tremor, they've mask type face, you know, shuffling a bit when they're walking and that's when you put it together with the story over the phone. Sometimes I have just gone, yeah, go ahead and start levodopa, you know, especially if I think there's going to be a delay with them being seen, you know, another way, like face to face. Yeah, so I think in certain ways it's definitely harder than others. I think we definitely miss some as well. I mean, sometimes, you know, you can misdiagnose, I think, essential tremor and PD, sometimes a bit hard to disentangle over the phone. But there are cases, I think, where if you get a kind of a decent referral letter from the GP, where they've examined the patient maybe in person themselves, that I've been quite happy to say to the GP, yeah, go ahead and try the levodopa. So, yeah.
Lovely. Okay. So a question from Nuri. So when you're doing that differential diagnosis and maybe you've got the PD diagnosis wrong, but you've initially started somebody on levodopa and it's making no difference.
Yeah.
There's a real problem that people don't accept the new diagnosis and it's challenging to get them off the treatment. Any advice at all?
Oh, yeah.
Huge, you know, you've got a second to do that. No, joking.
Yeah, that's really tricky. So you mean the patients you've started on levodopa already and then they're just not responding and then you're thinking maybe it wasn't IPD at all or that?
Yeah, exactly. Yeah. One of those.
Yeah, maybe I've been lucky because I think most of the patients I've seen have kind of been willing enough to come off when they haven't seen an effect, and I just say, oh, listen, you're on something that might be causing, you know, could potentially cause low blood pressure and other side effects, and you haven't really seen a benefit from it, so why don't we just take you off it? I found most people have been okay with that. But yeah, maybe I've just been lucky with who I've seen. I don't know.
Yeah, and maybe it is being very truthful about the knock-on effect of taking a drug that your system doesn't require, as you just said.
And I mean, it is always so hard sometimes when doing a diagnosis. I mean, I think we've all come across patients where you're trying to maybe undo a diagnosis that either you made or a colleague made, and it's not Parkinson's disease. And I think just being as honest as possible, I think that's the best policy, and just explaining, you know, things are grey in medicine, sometimes not black and white, and just hoping, you know, that the patient will be understanding. Mostly I found that they are, but yeah, it can be challenging.
Patsy, you want? Yeah.
Yes, and I would totally agree with that, Gemma. And I think it's managing people's expectations as well, isn't it? And you know what I frequently say to people, if I feel that they're not levodopa responsive and I'm gradually reducing it, that, you know, at any time, but you know, if you do feel that we're making you worse, then there's always grounds to put you back on that levodopa. And interesting as well, you know, absolutely not everybody has access to video links, smartphones, and again, sometimes you just have to see somebody face to face.
I agree.
No getting away from that.
Just a quick question from Sheba about the mocha test blind. Does it require a license to use it?
As far as I know, during COVID, at least, they've been allowing people, as long as you kind of register your details online, that then you're allowed to use it for free. And hopefully that hasn't changed since. But yeah, I think during the pandemic, they were making allowances with it.
Perfect. I'm going to stop there, but there are some questions still in the Q&A. So can I ask Gemma and Patsy to have a look at them and answer them, type the answers in whilst we close this part of the session. And I say a huge thank you again to both of you for a very stimulating conversation.